Thanks, Stephen. Health professional education is a long and interesting process. It takes place in carefully built silos that have evolved at the cutting edge of orthodoxy over the last 100 years or so. And we suffer from this kind of education. The silo approach to education has led to confusion about healthcare. Is it about getting and staying fit and well, as we've heard? Is it about healthcare providers? Is it about body parts and diseases? The complexity of interaction between wellness, illness, and providers is compounded by siloed education. The health workforce is a large and complex mass of people: cleaners, desk clerks, technicians, community workers, and of course regulated professionals. It's the most highly educated workforce in the world. Yet when it comes to working in an interprofessional team, it's frequently dysfunctional. It's the health system's belief, of course, that it works as a team. Yet global studies demonstrate the frequent occurrence of events that are adverse for patients. These adverse events occur because of the inability of healthcare workers to talk coherently with each other. In teaching health professionals, the patient is often lost in translation. Indeed, sometimes healthcare sounds as though it's all about healthcare professionals. The patient becomes the object and not the subject of attention. Teaching devolves into a lot of talking at and not very much talking about. We have to focus our education to reduce the duplication, which finds its way into practice. Valuable time, effort, and energy are lost when health care providers repeat, for strictly professional reasons, the same procedures as their colleagues. Scopes of practice are a problem. We have to focus on our educational attention on that fact that practice is about the patient. The patient should always be the subject of professional attention, not the object of some professional goal. Patient-centered care is not about moving a hockey puck. It's about caring for a person. One major problem of health professional education is that we train in different languages. Each profession has a secret code. I call it acronish. I'm going to write a book about it. Acronish. It's not surprising that adverse events occur when language used amongst health professionals has many attributes of the Tower of Babel. We think we're talking the same language, but frequently the language we think we understand leads to very different conclusions. Close to 80% of the workforce is female, yet we pay no heed to gender differences in language usage. And about 72% of that workforce are nurses. You think about it. Complaints addressed to the health authorities in BC are all too frequently attributed to poor information transfer. What's the probability of an honest answer to the question, does this make me look fat? Well, it depends on the person you ask. We have lots of analogs in healthcare of information fear. Much of the interaction in collaborative teams is about confusion in information transfer. Imagine in this discharge handoff the potential to get things wrong. 30 care providers could give incorrect information, could omit information, and could mangle information if the team's confused. No wonder the patient is. If confused and confusing language isn't enough to trip up team care, think about the environments in which care is provided or in which we teach. Talk about discombobulation. Finding a way through the mazes we call acute care settings seriously interferes with good teaching and practice. Every discipline on campus loves its own space. Every dean wants a new building. Think of all the simulation labs that are being built in the private territory of faculties X, Y, and Z. Can we expect health professionals to work together if they don't learn together? And we recognize there are no simple solutions to this problem. We suffer from 100 years of silo building and almost as many years of professional regulation and legislation. Change will take time, and it certainly will not come from a Google trademarked search. Take role clarification. tied up in scopes of practice, dictated by accreditation, and sanctified by legislation, of course, is it any wonder we see constant iterations of the theme, that body part or that disease belongs to us, not to you, hands off. We're getting there, but we're not there yet. So let's not expect some simple solutions, but let's at least apply logic to these problems. Let's assess their extent. Let's develop clear plans for change. Let's measure both the outcomes and the impacts. We owe it to future students and, of course, to our patients. The major movement to interprofessional collaborative education and practice will take collaborative leadership from post-secondary education, the health sector, professions, unions, and government. We can't go on expanding class sizes, training more and more and more at the expense of everything else in the country. Think of information, treatment, and discharge challenges. How healthcare teams define and solve these challenges are good indicators of the kind of collaborators they will be. Audrey Hepburn, my teenage heartthrob, once said, nothing is impossible. The word says, I'm possible. We can surely de-silo health professional education, produce new graduates who enter practice skilled in collaboration and with enough knowledge to work together in any kind of health team. We must teach our students to collaborate more and turf protect less, to build true interprofessional teams, to seed pieces of their scopes of practice, to make the patient the subject of attention, and to move out of silos. For the future of healthcare, there is no option. Thank you for your attention, all my relations.